My name is Dr Di Cori and I work as a consultant at the Hospital University of Pisa. I'm a cardiologist, but my field of interest is the management of cardiac arrhythmias. And when I say management of cardiac arrhythmias, I mean cardiac pacing, like pacemaker implantation and ICD implantation or lead extraction, and of course, ablation and electrophysiology. In my centers, we perform about between 1,000 and 1,500 procedures per year. 50% are procedures of cardiac pacing and 50% ablations. Regarding ablations, we should consider that this is a very heterogeneous group of procedures because it involves at least three main subgroups: the groups of supraventricular tachycardias, the groups of atrial fibrillation, and the group of ventricular tachycardia. These procedures are very different one from each other because different are patients, different is the type of procedure and ablation, different is the type of anesthesia, and different is, of course, duration, outcomes, and potential complications. We say that we have three main subgroups of ablation. Usually patients with SVT are patients young without major comorbidities. So in this case, usually these procedures are short, they last less than 1 hour. They don't require a general anesthesia because we work with a simple mild sedation. And all these patients usually experience a full recovery and no complications are usually observed. On the other hand, we have the group of patients with VTs. Ventricular tachycardias are expression of a cardiopathy. So these patients are old patients with many comorbidities and fragilities. They need long procedures under GA or deep sedation, and success rates may vary from patient to patient, and complications are not infrequent. In the middle, we have the subgroup of atrial fibrillation. Atrial fibrillation is the arrhythmia of the present and of the future because numbers are increasing, and we distinguish many different subtypes. Some AF are observed in young patients and they can be treated as SVT, but in other forms, and I'm talking about chronic forms and persistent AF types, they need a more complex treatment like observed for VT patients. Well, when we have to approach what we call a structural arrhythmia, and I'm talking about AF and VT, we have to consider that this patient needs to approach the left cardiac chambers. It means that we have to go inside through a transeptal or through a retrograde aortic approach. So we work in the systemic circulation. This is one point. The second one is that to do so, we need a general anesthesia. And third, when we are inside, we tend to perform many radiofrequency applications. So the duration of ablation is consistent. There are many different techniques that we can use to ablate. We can work with radiofrequency, we can work with cryo, we can work with PFA, the last new in the world of EP. I'd say that these techniques are different, obviously, but what makes the difference is the type of patient and the type of arrhythmia, because it's according to this scenario that we have to decide what we need to monitor and how. Generally speaking, we distinguish two different approaches, what we call thermal injury. And when we talk about thermal injury, we mean radiofrequency or cryo. On the other hand, we have the new technology, which is PFA. In the world of pulse field ablation, we work differently. The damage is not thermal, and the final result is the result of a phenomenon called electroporation. In both cases, what we want to have is the disruption of cardiac tissue in order to prevent recurrences of the specific arrhythmia. When we perform an ablation, as observed in many other settings like cardiac surgery or non-cardiac surgery, hemodynamic stability is essential. So when we perform these procedures, we need to monitorize all these parameters: ECG, oxygen saturation, and of course, blood pressure. A definition of hemodynamic instability can be challenging. Generally speaking, I'd say that we have an hemodynamic instability when it's impossible to give an appropriate organ perfusion. And this is the typical qualitative definition we can give for that. But in one word, it means hypotension. So the question is, what could be a quantitative definition of hypotension? When we talk about hypotension, it's really challenging to give a quantitative definition. In a previous published paper, more than 150 definitions of hypotension have been found in previous published paper. It means that this is difficult. Some groups use systolic BP to define hypotension. Other groups tried with the use of mean BP. And again, many difficulties are met considering severity, considering duration, or a combination of both. Usually I'd say that the most used definition for hypotension is a decrease of systolic BP more than 30% respect to baseline. This is a definition. Another possibility is a reduction of mean BP less than 65 millimeters of mercury for more than 5 minutes. As I said, EP procedures can be performed under many different anesthesiological regimens. When we work under mild sedation, usually hypotension is not an issue. Different from cases where we need a deep sedation or a general anesthesia, because in these cases, hypotensions are very frequent and very often they are related to the anesthesiological regimen. In addition, we have to consider that in many of these cases, it's likely to induce arrhythmias during these procedures. So if we have a frail patient with a very fast arrhythmia, the risk to have not only an hypotension, but also a true hemodynamic instability may be consistent. Traditionally, during EP procedures and ablation, we can use many different ways to check BP. As I said, for SVT, when we are expected to have easy arrhythmias to ablate, usually we work with a simple arm cuff. So we check BP intermittently every 5 minutes. When we ablate patients with PTs, this is a much more complex scenario, and in these cases, we need a continuous BP monitoring. And historically, it was done using the typically A-line, so invasively. And almost the same was for IF ablation. At least in Italy and the majority of South European countries, an A-line is used to perform PV isolation or ablation of the substrate during IF. In other North European countries, practice is for an intermittent arm cuff. But anyway, usually I'd say that the A-line is the traditional approach to have a continuous BP monitoring. In my centers, we perform ablation since 2000. And we have been strongly believed that a continuous BP is mandatory in order to perform in safety an IF ablation. The reason why we decided to use from the beginning of our experience a continuous BP was that during an ablation, like an IF ablation or a VT ablation, very often you can have hypotensions. These hypotensions are related to the anesthesia. These hypotensions can be related to arrhythmias, and not least, these hypotensions could be related to complication as intrapericardial bleeding and cardiac tamponade. In all these cases, if you have a continuous BP, you can be sure to work in safety. In the last 3 years, we changed consistently our practice because believing in the role and in the need of a continuous BP, we decided to switch from the A-line to the non-invasive continuous BP monitoring. I remember very well at that time, I decided to surf on the web to look for something which could allow to have this information, but non-invasively. Because many complications usually can be observed with an A-line, has vascular complication, has infection, or also a simple patient discomfort immediately after the procedure. when we started our experience with the finger cuff, obviously I had 3 questions to address. The first one was to understand if this technology works, so I mean reliability in my field. The second one, if it could be considered useful, and not least, if we can consider it affordable. In terms of reliability, we perform a pilot study to see if in a setting like my settings, IF or VT or ablation, I mean the world of arrhythmias, where our rhythm is often unstable, this technology could work properly. Our results were absolutely remarkable, because we have seen that in terms correlation are very good for systolic, mean, and diastolic BP, not only in sinus rhythm, but also during atrial fibrillation. The second question was to evaluate whether the technology can be useful, because we didn't have this information. As I said, for many years we have been working with A-line. When you work with A-line, of course, you can see BP during your procedure, but it's impossible to review all your data. So the question is, what happens during an AF ablation? We experience hypotension, and if yes, how much? And using Demosphere technology and ClearSight and Acumen IQ, we had the opportunity to review all this data. And our results were absolutely impressive, because we have seen that, first of all, when we ablate under mild sedation, hypotension is not an issue. But when we work under GA or under deep sedation, this patient experiences hypotension in more than 20% of time. And this is a lot of time. The conclusion was that absolutely, when you decide to work under GA, you need once again a continuous BP monitoring. And this is a perfect way to work without the A-line. And the third point is about affordability. Obviously, when we compare the cost of a non-invasive BP versus an A-line, apparently the cost is of non-invasive system could appear more important. But we should take in mind that this cost should be evaluated in comparison with the cost of complication observed with the use of an A-line. Because when you have a complication, the complication is expected to prolong the hospital stay. So the final result is that it's better to put it on and to work with that, avoiding any approach to arteries if we can.